I nerd out about some of this topic particularly is because of all things we love in nature. Okay, as normal, your pants blueprint and all things of this. So diabetes. Diabetes is fascinating, I think, right? So as a brief reminder, you guys know the type 1s and type 2s. We're really focusing here on type 1 because it has less to do with the life cycle, the lifestyle of the pediatric patient, more to do with their genetics and that 2-hit hypothesis again. You had the genetic setup for this, and then something else happened that has triggered your beta islet cells of your pancreas to no longer want to make insulin. So is that a virus? Is that some other kind of illness? Is that a pediatric cancer? Potentially, you have all types of those things. But ultimately, your beta islet cells of your pancreas are just no longer making insulin. Type 1, less to do. Anything in the life cycle. Then type 2, more lifestyle in nature, where functionally your beta islet cells work just fine, but your body needs so much more insulin that your beta islet cells are getting flogged time after time to just make more insulin until they just kind of poop out. And they're like, I can't do this anymore. I cannot continue to make the insulin at the level that you are requiring for either the body mass, size. I do not have enough in me, no matter how much you flog me to be able to do that. When you look then at how much we are talking about the levels, this is nice because it is very similar to the adults. It is actually the exact same. So if you are looking at a child who has dysglycemia, so an impaired glucose, so an impaired fasting glucose, after 8 hours, their glucose is still between 100 and 125. If you have an impaired glucose tolerance test, they've taken this 50 grams of an oral glucose solution that if you've ever tried that, it's like, I don't even know if Elf could get this down. Like, that's how sweet it is. Like, it is just, what was his 4 food groups? Just an Elf? Candy, canes, candy corn, and syrup. That's incredible. But yes, that's functionally what we're having these patients and kids drink. So even these kids have trouble getting oral glucose down. That's how sweet it is. Like, I don't even think Elf can handle it. Okay? So if you're above, at the 2-hour mark, still above 140, you're saying, I don't have enough insulin to be able to do this. And then the A1C between 5.7 and 6.4. Versus diabetes, where your fasting is above that magic 126, which is just too high for a kid or an adult. Your 2-hour oral glucose tolerance test is above that 200 mark, and your hemoglobin A1C is above 6.5. Now, this is where I'm going to nerd out on you, because of all of my favorite labs, hemoglobin A1C is my favorite lab. It is the coolest lab. Okay, remember this morning, I started off with, how is hemoglobin made? What chains are made? Alpha and beta, right? And what kind of, is hemoglobin circular? It's like a platform, right? So it should be all twisted and folded up. Normal hemoglobin. That is how hemoglobin is made. Kind of twisted up on itself with no open ends. About 1% of hemoglobin is in its linear form, right? So in its linear form, it's opened up, those chains are opened up, and the end of that has one little hydroxyl group, one little OH group at the end. And so in that linear form, that one hydroxyl group can attach to glucose. And when it attaches to glucose, it does not let go of it. It cannot function again in its circular pattern. It cannot, again, fold up on itself. It just carries that glucose throughout its life cycle. So it just has this glucose that is attached to it and this open hemoglobin. Now, why is that interesting? Well, what hemoglobin A1C is looking at is what percent of that 1% that's open has an attached hemoglobin. So when we're saying hemoglobin A1C was 5.7, 5.7 of the 1% of open hemoglobin has an attached glucose to it. That's the coolest lab. Like, did somebody figure that out? And that's why you can only do it every 3 months, because every 3 months is the life cycle of a red blood cell, right? So if you're checking this more than that, you're like, that's not going to do any good, because I know that the red blood cells that were open and the hemoglobin that's attached is still attached. So that's why every 3 months you're doing this, because it's hemoglobin related. Hemoglobin, 120 days. The 1%, what percent of the 1% is what you're looking at. So that determines, you can extrapolate that to say how bad is your diabetes if we know that's what's going on. So the coolest ladder. I will never get over hemoglobin A1C. My whole life. Will never get over. Okay, that was, either way you can do that for type 1 or type 2 to look at the control of how much circulating glucose do you have. But when we're looking at type 2, when I was in residency, we really functionally didn't even talk about type 2 for adolescents. We were like, it's really not this entity that we see that much. By the time I get back here to teach, it's in every textbook. We're talking about it frequently. Oh, and now I prescribe metformin for people, right? That was not one of our meds that we looked at all. So type 2 is this emerging entity, or it's emerged, it's here, that we see in teenagers due to this obesity crisis. And the beta islet cells are being flogged to push out insulin, but they cannot keep up with that peripheral circulating insulin. Thus, you end up with this type 2. The same type 2 related functions are going to, or the type 2 related issues with high glucose are going to be the same that you see for all of them. So, glucose. Glucose itself, circulating glucose, is extracellular or intracellular? Extracellular, right? Insulin is what makes it go from extracellular to intracellular. Sugar, glucose on its own, toxic to small vessels. Where do you have small vessels? Eyes, peripheral nerves, kidneys. Right, so that's the particular places you see this from that extra circulating glucose. It is eye issues, peripheral nerve issues, and feet, hands, anywhere else, and then your kidney function. Right, so this is what is happening now that we start seeing in teenagers that we didn't see before. Is you have this early destruction of those small vessels from this high blood sugar that is going to be a significant problem for you guys, particularly, especially if you don't want to see pediatrics. Because you're going to see this earlier and earlier in adults with these more concerning secondary effects of this. The onset for these kids, certainly it's going to be pretty insidious. You see this increase in weight gain. Certainly they could be very tired if they're not able to take those extracellular glucose and make it intracellular. You can present with that acanthosis nigricans. I always say I had a friend who, yes, the child was obese. Yes, the child had significant risk factors for diabetes, but the child did not, in fact, have diabetes, despite having a documented acanthosis nigricans. The child was just a nicky child and dirty. So sometimes if you think it's acanthosis for a child, take an alcohol wipe and just see if it wipes off. Because oftentimes, especially young boys, they just don't wipe. So acanthosis, is it acanthosis or is it big? One of the things to see. But acanthosis, certainly you're going to see that there. And then symptoms that look more like that type 1. So an example of acanthosis in a child, you're looking at a child typically obese in that same pattern that you do see for adults. When you're looking at type 2, you're looking at slightly elevated. So I get asked this every semester. What is slightly? How slightly is slightly? I'm telling you, if I give that to you on a test, it will look slightly. You will know that it is slightly elevated, above 126 or above 200, to determine that it is type 2 versus type 1. If the lifestyle and interventions are going to be your treatment of choice 1, if it is persistently elevated, they also can use metformin. So teenage children and teenagers, also a candidate for that. And then you start looking, oh my goodness, you already have some of these adult type pathologies. Let's look for the rest of these adult type pathologies. Hyperlipidemia, high blood pressure, and a PCOS. Type 1, we used to call this juvenile diabetes. We really don't use that as much anymore. It's changed names so many times, and it was insulin dependent. Now it's just type 1, type 2. So just some historical naming there. So first will happen is your beta islet cells will have some sort of destruction, though you don't see that clinically yet. That is stage 1 that is happening. Stage 2, where they can no longer keep up with the demands of insulin. Stage 3 then is that honeymoon period where there's like the last stand. So I guess, I don't know why I'm thinking about the Alamo today, but apparently I am. Where like, there's like one last stand at the Alamo. It's kind of like that with the honeymoon period, where they're like one more fight and then all the islet cells just die. And then now you have diabetes. Typically you see this in those younger kids, school-age children to early teenage years. I will say though, the youngest child I have diagnosed with diabetes was 18 months old. So you do see this down into very, very young children, so something to be aware of. Again, autoimmune destruction of those beta islet cells in the pancreas, they will need lifelong insulin until one of you in this room develops a synthetic pancreas, and then we will cure diabetes. Somebody someday will be teaching IPAP about the synthetic pancreas. In this honeymoon period, then we're at the last stand of those beta islet cells where they'll resume function. And this is really where the hot topics of research are, right? It's hard to say who is going to develop diabetes, but once we know that there's beta islet cell destruction, can we keep this honeymoon period going as long as possible or forever? So this is an area of hot research of how long can we keep that going. So this drug now that we have for kids, teplizumab, basically helps these beta islet cells, just kind of babies them along to make insulin as long as we can. So that likely will be where we all see this someday is, oh, this is obviously what we give people with new onset to harness this factor. So things to be aware of someday. Most of your diabetics going to come across in different genders. You see this peak when they're younger, and you see this peak in adolescence again. Puberty can affect this, so you see this is a little bit younger, and it clusters in families showing that there is some sort of genetic indication. So what is causing this? So like I said, we don't really know. So that's exactly what it is. We don't really know. Is it some virus that caused it? So the ones that have been hypothesized, enteroviruses, you see it higher in the summers. Mumps, rubella, we don't really know. Is it that we're too clean, right? We have hand sanitizer literally everywhere, and C-sections, and we give babies baths right away, all this. Are we too clean? And these kids, then their immune system starts turning on them. Is that what the hypothesis is? Is that we changed our GI microbiome, and that's what this changes? Is it some sort of dietary factor that we have in all the dyes? Is it some sort of stress factor? Nobody knows. Function. Really, to say is if you really like research, this is an area, this is a hot topic to go into. Will be something that you see more over the years. I have beef with the way that they talk about the 3 Ps. You guys always end up being polyuria, polyphagia, polydipsia. If you think about the physiology of this, I'm a physiology purist, it really gets me every time, right? You just told me that glucose was extracellular and going to intracellular. So the first thing actually that's happening is polyphagia. You are hungry because you cannot get glucose into a form, even after you've ingested it, that it becomes usable. So you are functionally very hungry at first. Your body's in a catabolic state trying to break down muscle, which is ketones. And so first thing is actually polyphagia. The next thing then, now you have all this extracellular glucose running around, and so you must dilute that to keep in a homeostatic environment. So the second thing is a polydipsia, to be able to dilute all of your extracellular glucose. Finally then, because you have all this extracellular glucose, you diluted it, now you have polyuria. So it should be polyphagia, polydipsia, polyuria. It's just not how we learn it. So the physiologist and me nerds out about that. The other thing that will happen is about 300. So once you get to about 300 in a child, their kidneys can no longer take this anymore, and so they will just start, they cannot even filter past that. So that's also not just because you have more of that diluted intake, but the kidneys can't filter after that in most kids. And so after about 300, if you see glucose spilling in the urine, you can just guesstimate that it is probably above that 300. Because it cannot become intracellular, you have these weight loss, these hectic states in this kid. And you typically see it, the most frequent presentation that I've ever seen is a kid that was dry at night. So they had no issues, they are completely potty trained, and now they are having accident after accident after accident at night. So if you see new onset nocturnal enuresis, that could be something to think about. Is this diabetes? That should be on your differential. Certainly, if they're fatigued and weak, you don't have that caloric intake that is in a usable form. And if you end up with blurred vision, it's much more severe. Something else to think about, if you're over that 300 mark and you are spilling glucose into your urine, now you have a whole bunch of glucose in an area that already has a whole bunch of bacteria, so you're more likely to have yeast infections out of nowhere because there is something for them to eat. And then DKA, so one of the most common presenting symptoms in kids who compensate really well until they don't, is that they hit DKA. So we will pick up with that at DKA next time. I think I don't see